Thanks for flexing around the weather. Um, and it's my pleasure to introduce Dr. Ninel Hovnanians, who is a clinical assistant professor with us at Northwest Hospital, where she is a general cardiologist and director of our cardiac rehabilitation program. Ninel did her medical training at Islamic Azad University, where she has her degree, and then her residency at Jacobi in New York, and her fellowship in cardiology at Einstein. And she has chosen to take on the extremely challenging topic of POTS, of postural orthostatic tachycardia syndrome. And it's a pleasure to have you with us this morning, Ninel. Thanks for joining and being flexible about where we are to give the talk. And over to you.
Good morning. Thank you, Greg, for that kind introduction. I apologize for all of you having to see my presenter view. We tried to figure this out, but somehow it failed us. So you may see some of my notes. I chose to talk about POTS, not because it's a primary cardiac problem. And I know that we all see a huge number of these patients. My curiosity was triggered when I suddenly started seeing a huge number of these patients, an influx of these patients into our clinics, whereas before, during my training and fellowship, POTS was maybe one line that you read about and maybe saw one or two patients throughout all of fellowship in EP clinic, and was never expecting to have to see such a huge number of patients, especially after COVID. So started reading about it and decided to share some of the info that I could gather today, as inevitably we'll all be seeing these patients in clinic. I do not have any disclosures. The objective of this talk is just trying to understand the basic pathophysiology of this condition, know the diagnostic criteria, and most importantly, how to manage these patients. So by definition, POTS is a clinical syndrome of orthostatic intolerance characterized by a heart rate increment of 30 beats or more, often a heart rate of over 120 beats per minute within 10 minutes of standing or a head-up tilt, and in the absence of orthostatic hypotension. The heart rate criteria, if the patients are younger, less than 20 years of age, is an increment of 40 beats. It affects about 0.2 to 1% of the general population, and there are 1 to 3 million people affected in the United States. It's predominantly in young women between the ages of 15 to 45, with a female to male predominance of 5 to 1. The onset of this condition can be acute, subacute, or insidious. Most frequently, it is preceded by a viral illness. In many of the cases, patients are healthy and active individuals. They're competitive athletes or high-performing high school or college students, which is why this condition is extremely frustrating to them and really affects their quality of life. So what happens to us as normal individuals when we stand up? So when we stand up, there's venous pooling and there's a shift of intravascular fluid into interstitial space. There's a decrease in central blood volume, which leads to a decrease in stroke volume and cardiac output. At that point, the baroreflex counterregulation kicks in. There's an increase in heart rate, vasoconstriction, and humeral activation. So there are multiple systems here which are activated to maintain the blood flow to the body and the brain when we stand, which then causes only a small increase in heart rate of about 5 to maximum 20 beats per minute, a small drop in systolic pressure, and an increase in diastolic pressure. But these changes are so minor that we don't really feel it. POTS patients have an exaggerated response to this change in blood distribution due to abnormalities that can affect the different parts of this compensatory mechanism. And that's why there are different subtypes to POTS. So I'll go over the different systems that can be affected that can cause symptoms in these patients. So one subtype is the neuropathic POTS, which is caused by an impaired sympathetic vasoconstriction. which leads to excessive pooling of blood in lower extremities, causing a reduce in venous return, and then the compensatory tachycardia to be able to maintain the cardiac output. The patients with neuropathic POTS, more than 50% of them have loss of sweat function in the distal lower extremities, and this is due to small fiber neuropathy. A second subtype is volume dysregulation. A lot of these patients actually have reduced blood volume due to abnormalities in the renin-angiotensin-aldosterone system. And there's a paradox here because despite their hypovolemic state, these patients exhibit inappropriately low levels of plasma renin activity and aldosterone, so they're not able to regulate salted water, basically. Hyperadrenergic POTS, these patients have an elevated sympathetic nervous system activity, and they're characterized by an increased level of plasma norepinephrine levels upon standing. A lot of these patients, when they do the tilt table test, they actually completely vasoconstrict, their extremities become really cold, and they kind of present like a patient that's going into shock in terms of symptoms. The hyperadrenergic POTS can actually be triggered by certain medications in patients that are susceptible to this condition. Bupropion, tricyclic antidepressants, and sympathomimetics like methylphenidate and medication used in ADHD can trigger POTS in this population. And this is because it affects the clearance of the norepinephrine. These medications affect the clearance of norepinephrine from the synaptic space. And a lot of patients that I have seen in clinic actually have the diagnosis of ADHD, and they have been started on stimulants, and now they're presenting with symptoms of POTS. There's also the baroreflex dysfunction, which are abnormalities in the baroreflex sensitivity, which causes an inappropriate cardiovascular response to postural changes. Mast cell activation disorder, which is an inappropriate release of histamine and other mast cell mediators in response to physical activity or orthostatic stress. These patients present with symptoms of POTS, but also flushing, shortness of breath, excessive diuresis, dermatographism, GI symptoms like diarrhea, nausea, vomiting. And these episodes can be triggered by a multitude of things like standing, exercise, but even in women premenstrually or after meals, they can have more severe symptoms. The theory of autoimmunity, which is basically having antibodies against adrenergic receptors, alpha-1, beta-1, beta-2, and acetylcholine receptors, which then alter vascular tone and heart rate regulation. The autoimmune theory is, the data behind it is weak, but it has been studied in small series that they have found autoantibodies against these receptors. The deconditioning, which I think is one of the most important things that is not given enough importance. So prolonged physical activity actually causes a reduction in blood volume, cardiac mass, and stroke volume, and then it causes the compensatory tachycardia that we see in patients. And I'll explain a little bit more about deconditioning in the following slides. And then immune triggers, again, we know that a lot of these cases are seen after viral infections, especially with COVID. We see a lot of these cases, vaccinations, or sometimes even other stressors. So let's talk about a little bit about this concept of deconditioning and bed rest and microgravity. So gravitational and hydrostatic gradients play an important role in determining the distribution of pressure or volume in the cardiovascular system, and orthostatic intolerance is actually a very well-known complication of space travel and bed rest. When these forces are removed, a central fluid shift occurs, which starts a cascade of neurohormonal changes, leading to a reduction of blood and plasma volume. And these adaptive changes actually happen pretty rapidly, and they're almost complete by 24 or 48 hours of bed rest or lack of gravity. Back in 1997, Dr. Levine, who's one of the physicians who's done a lot of research and study on POTS, and his colleagues conducted an interesting study on 12 individuals between the ages of 19 to 29. So they brought these patients into the lab. They did a baseline right heart catheterization, echo, measured blood volume, urine sodium in the beginning of the study, and then they had the patients do 14 days of bed rest, head down bed rest in -6 degrees. They were only allowed to go up on one elbow for meals, and they were given a regular meal with liberal salt and fluid intake. And then at the end of the 14th day, they kind of repeated the same thing. They did a repeat right heart cath, repeat echo, and measurement of blood volume to see what changes occurred during this time frame. And what they saw is that there was a 5% decrease in cardiac mass. There was a 16% decrease in LV and diastolic volume. There was a 12% decrease in stroke volume, 17% decrease in plasma volume, and an 18% decrease in pulmonary capillary wedge pressure. And all of these patients, after this period of bed rest, had orthostatic intolerance. And these changes were basically similar to what was being seen in astronauts after being in space for about 2 weeks. So then years later, they kind of repeated the study. They repeated the first part of the study by, again, this was on 7 individuals, so a much smaller group of patients. They had the 18-day bed rest instead of 14. They did a right heart cath, measured all the parameters that they had done in the prior study. And then they brought these patients back about a year later, and the reason there was a gap between the two parts is that they wanted to minimize the fluoro and radiation to these patients. And then they gave them Lasix. They gave them Lasix to create an acute hypovolemic state to see whether the changes that the orthostatic intolerance and the changes that we were seeing in these patients was whether or not it was purely because of hypovolemia. And they saw that although both conditions resulted in similar reduction in plasma volume, the supine LV and diastolic volume was reduced more after bed rest compared to acute hypovolemia, which provides evidence that the LV remodeling during bed rest is an important factor in the symptoms of these patients. And the stroke, they saw that the stroke volume was reduced more for any given change in filling pressures after bed rest compared to acute hypovolemia. And patients had more severe orthostatic intolerance after bed rest compared to the hypovolemic patients. So this is why the POTS and the deconditioning is more than just the hypovolemia that occurs. It's a more comprehensive change in the cardiovascular system. So then you have these susceptible patients, whether they're genetically more susceptible or have underlying conditions that they make them susceptible to POTS. You have an inciting event like an infection, a concussion, an injury, enforced bed rest. They start developing symptoms of orthostatic intolerance, which can be seen very early, as we talked about, of bed rest. They have exercise intolerance, they're dizzy, they're lightheaded, which automatically causes them to have diminished activity. Further bed rest then comes in the cardiovascular deconditioning, decrease in blood volume, stroke volume, cardiac atrophy. You have a sympathetic activation, which is an exaggerated response to an upright position, which causes them to be symptomatic, which then leads to worsening of their symptoms, more orthostatic intolerance, more exercise intolerance, and this vicious cycle just continues, and these patients tend to get worse and worse with time. So some of the common symptoms that these patients present with, so there are a lot. It's lightheadedness, tachycardia, palpitations, headaches, weakness, fatigue, brain fog, difficulty concentrating, memory problems, GI symptoms like nausea, bloating, abdominal pain, blurred vision and visual disturbances, dyspnea, chest pain, syncope and pre-syncope. And just looking at this combination of symptoms, it's not surprising that these patients are going from clinic to clinic, from GI to neuro to cardiology, because their symptoms are so varied and affect almost all of their organ systems. And there are a bunch of conditions that are associated with POTS. One of the common ones that we see in clinic is Ehlers-Danlos, and this is the type 3, the hypermobility type, which is basically the less severe type, because they don't have the aorthopathies and other conditions that other types of Ehlers-Danlos syndrome patients have. The possible pathophysiology that's been suggested in these group of patients is a generalized connective tissue laxity, which causes an increase in vascular and venous compliance, leading to insufficient vasoconstriction when these patients stand, which predisposes them to orthostatic intolerance. A lot of these patients also have small fiber neuropathy, which causes autonomic dysfunction. And these group of patients are actually, I mean, we'll get to treatment, but in general, these group of patients are more intolerant to beta blockers, and they do better with medications that increases vasoconstriction, such as midodrine. Other conditions is this hypervigilance, fibromyalgia condition. These patients have it's a perceptual amplification in hypervigilance, which is described in patients with chronic pain like fibromyalgia. They have an increased sensitivity and aversion to somatic and tactile stimuli and pain. And these patients exhibit an increased sympathetic nervous system activity, which is why POTS also comes into play in these patients. Some functional gastrointestinal disorders like IBS has been associated with POTS. Chronic fatigue syndrome, there's a huge, significant overlap between these two conditions. Headaches and migraines, a lot of these patients suffer from migraines, and again, one of the other reasons they're being seen by neurology, and psychiatric conditions like anxiety and depression. And this is, I think, a two-sided association. One, because POTS is a chronic condition. If these are young patients, their quality of life has been affected, so a lot of them have anxiety and depression. And the other side is a lot of patients that have anxiety and depression are on medications, which can actually trigger POTS in them. So now we have this patient that's coming into the clinic. How do we diagnose it? So the diagnosis is a combination of clinical history, physical exam, routine blood work to rule out conditions that can mimic symptoms of POTS, anemia, thyroid dysfunction, cortisol levels, or some of the routine labs that we can check. ECGs are done on anybody who presents with syncope. They're going to get an ECG. And then an active stand test. So the active stand test is actually a really simple evaluation for POTS, which can be done in clinic with just a blood pressure cuff, which is basically doing the tilt table test, just without the passive tilt is a more active test, which makes it even more specific for POTS compared to the head-up tilt. And it's done with patient lying flat for 10 minutes, getting baseline blood pressure and heart rate. Then you have them stand up unassisted, and their blood pressure is checked at 135 and 10-minute time frame. And the same criteria that's used for diagnosis of POTS in terms of the heart rate increase is used here. And this test is as sensitive as the tilt table, and as I said, even more specific. So this should be the standard of care for anyone who is coming to clinic with a suspicion of POTS. But then if they come in and they have more symptoms that makes us suspicious that they have more involvement of the autonomic nervous system, at that point, a complete autonomic testing can be considered and ordered. In most of the autonomic testing, the more common autonomic testing include a cardiovascular reflex testing and a pseudomotor function testing. And the cardiovascular reflex testing consists of three parts. One is a heart rate response to deep breathing. This basically assesses the parasympathetic response by measuring heart rate variability. The Valsalva maneuver, which evaluates both the health of basically the sympathetic and parasympathetic functions by analyzing the heart rate and blood pressure during Valsalva. And then the tilt table test, which is basically a passive the passive version of the active stand test. The second part is the pseudomotor function test, and this portion is meant to evaluate for small fiber neuropathy, and it consists of two parts. One is the quantitative pseudomotor action reflex test, which is the measurement of sweat production in response to acetylcholine, which assesses the postganglionic pseudomotor function. And the second part is the thermoregulatory stress test, which evaluates the body's ability to sweat in response to increase in body temperature. As I mentioned earlier, the certain subtypes of POTS have a lot of abnormalities in the sweat, in lower extremity sweating and their pseudomotor function. So this is the Canadian Cardiovascular Society's algorithm in terms of what to do when these patients present to us. So you have the initial evaluation, their history, vitals, ECG. You order the routine testing to rule out any other abnormalities that can mimic their symptoms, and you do an active stand test. If their diagnosis is clear, then no further testing is really required, and you can move to management. But if there's conditions that are making you concerned for other pathophysiologies, that is when basically we as cardiologists come in. If there's any suspicion for structural heart disease leading to syncope or tachycardia or any sort of arrhythmias that are not purely sinus tach, then they should be referred to us to get ruled out with a Holter, with echo, if stress test is needed, if they're presenting with chest pain in a patient that may have a higher risk of coronary artery disease. If they have any sort of neurological deficits, if they're complaining of neuropathy, numbness, tingling in their extremities, or if there's concern that the syncope could be a seizure event, then they should be referred to neurologists for EEGs or EMGs, or if, again, there's a suspicion for more severe, then they have an official, be referred to autonomic centers where they can have official autonomic testing done. So basically, not all of the patients need to be sent to subspecialties. They should be able to be managed by their primary care doctors. The management is divided into two categories, the non-pharmacological and the pharmacological. I think that for the majority of the patients, the non-pharmacological interventions that we do have good results, and we don't even have to go to medications. And the non-pharmacological management really focuses on physical reconditioning, volume expansion, and symptom management strategies. So exercise is truly the cornerstone of management in POTS patients. They obviously have a lot of orthostatic intolerance, so they're not going to be able to get on a treadmill or start running. So the exercises should be started, need to be horizontal, like rowing, swimming, recumbent bike, to avoid exacerbating their symptoms. And then as they improve, they can gradually transition to more upright position. If they can have a supervised training, this really maximizes their benefits. There are two very well-known exercise programs out there. One is the Levine protocol, which was developed by Dr. Levine. It's a 7-month program. Again, begins with gentle exercises and gradually builds up. And the second one, which I give to my patients in clinic, is the CHOP modified protocol. This was developed by Dr. Boris at the Children's Hospital of Philadelphia. It's a modified Levine protocol. It's tailored for younger patients and patients who have more severe symptoms. And this is basically the breakdown of what that exercise program looks like. So months 1 to 3, it's purely horizontal exercises with recumbent biking, rowing machine, or swimming and kicking laps. Month 4, if they're tolerating those exercises well, they can then move to an upright bike. And month 5 is when they basically go really to standing with the elliptical machine, but without using the arms, and then treadmill, but purely on a flat ground. And then month 6 and beyond that, if they're doing well and tolerating, they can continue building tolerance and then progress to jogging. So second part of this non-pharmacological management is volume expansion. And this is where the increase in salt and water intake comes in. It's recommended for patients to take in at least 5 to 10 grams of salt per day with 2 to 3 liters of water. For patients, and this is purely in the short term, if they can't, for whatever reason, if they're sick or they're nauseous and they can't tolerate oral fluids, for 1 or 2 days, they can have IV fluids, IV normal saline, but this is really a short-term strategy. There's no data to support ongoing management for POTS with IV fluids, where we see in some POTS clinics just give patients IV fluids on a chronic basis, but there's really no data for that. And compression garments are actually really helpful in these patients. They decrease venous pooling and improve symptoms. Ideally, they want to wear waist-high compression socket garments with about 20 to 40 millimeters of mercury of compression, and abdominal binders are even more effective. So if they tolerate that, that would be ideal. And then teaching them some physical countermeasures when they actually do stand up and have symptoms like leg crossing, squatting, muscle tensing. This basically helps with the venous pooling, with the muscles contracting in the lower extremities and moving the blood. So these are some of the things that we can tell them, same as deep abdominal breathing, which helps reduce their heart rate and symptoms when they're struggling. And then insomnia and sleep disturbance are also very prevalent in POTS patients. They already struggle with chronic fatigue. On top of that, they're not sleeping well. So having a good sleep hygiene is also extremely important, making sure they limit caffeine or any stimulants close to bedtime, that they exercise, they have a good routine of getting up and sleeping at the same time, turning off screens, avoiding heavy or fatty meals close to bedtime. And this would just help improve their quality of sleep and hopefully provide them more energy. And then since most of our patients are young and they all love using apps and their smartphones, there's actually an app called POTS, which helps them track their symptoms. They can track their fluid intake, salt intake. The CHOP exercise protocol is actually embedded into this app. It's available for both iPhones and Android devices. So I tell my patients to download this on their phones and track their symptoms. And I feel like they like that. So now if all of these measures don't work, the patients are still symptomatic, then we can consider starting medications for them. And we try to tailor the medication as much as we can, depending on their underlying pathophysiology. So beta blockers are one of the most commonly used medications. Both selective and non-selective beta blockers like metoprolol, bisoprolol, and propranolol can be used. These medications decrease heart rate, improve orthostatic intolerance. They reduce that hyperadrenergic state that some of these patients suffer from, and they improve their exercise tolerance. But again, a lot of these patients are young female patients that have already pretty low blood pressures and already are suffering from chronic fatigue, so they don't tolerate beta blockers well. Ivabradine is another agent. This is, as you all know, is a selective sinus node inhibitor. Its use for POTS is an off-label use, but a lot of patients that haven't tolerated beta blockers, I've noticed that do better with ivabradine. The problem is that, again, it's an off-label use. Insurance companies don't approve them, and the patients that I have that are on them actually get it from Canadian pharmacies. Fludrocortisone, which is a mineralocorticoid receptor agonist. This medication can be used in conjunction with water and salt. It's most useful in people who have that hypovolemic POTS picture more, but obviously they need to be monitored for side effects similar to side effects like hypokalemia, or patients who have baseline hypertension, then this is not a medication that they can use. Midodrine, which is an alpha-1 agonist, increases peripheral vascular resistance, increases venous return, and it's most useful in patients with neuropathic POTS or patients who have Ehlers-Danlos syndrome. Pyridostigmine, acetylcholinesterase inhibitor. I have to say I have never personally used this for patients with POTS, but it does enhance the parasympathetic activity. And it is again, it's an off-label use of this medication, but it can be used. And then SSRIs are purely to treat the anxiety, depression part of POTS and not directly for the treatment of POTS. And I found a couple of case studies of using low-dose naltrexone and IVIG in patients that had mast cell activation symptoms and POTS, but again, there's no good data on this. So again, this is the Canadian, I really like their algorithms for POTS step one, you go to non-pharmacological, remove pulp withdrawal of whatever culprits, medications that can exacerbate their symptoms, hydration, salt, exercise, compression garments. And if this is not enough, then to move to step 2, which you can choose the medications depending on their predominant symptoms. So if the tachycardia is what they feel and they're bothered more, you can start with beta blockers and then move to ivabradine. If they have low blood pressure, a baseline midodrine or pyridostigmine can be used. The hypovolemic patients can use fludrocortisone, and in short periods, maybe IV fluids. And then the patients with more hyperadrenergic can again use the beta blockers. Methyldopa and clonidine are also medications that have been used for their treatment. And then I feel like I couldn't have talked about POTS without talking about COVID and the prevalence of POTS in COVID patients. So it has been reported that 2 to 14% of COVID survivors suffer from POTS or some degree of orthostatic intolerance. So they may not really meet the criteria of that 30 beats per minute of increase in heart rate when they stand, but they do have the symptoms of lightheadedness, dizziness when they stand up. To date, there's 777 million people that have been contaminated by have had COVID, and this is only the reported number. We know the actual number is probably way higher than that, and the speculated. So that is a huge portion of the population that suffers from that could potentially have POTS and orthostatic intolerance. The speculated pathophysiology in long COVID and POTS is it's divided into either the direct toxic effects of the virus on the autonomic nervous system, again, that autoimmune component of antibodies against nerve fibers, adrenergic and acetylcholine receptors, and then the deconditioning and bed rest and the hypovolemic aspect that comes afterwards. And in this study, they actually looked at what percentage of long COVID patients had criteria for POTS, and it was 79% of patients that were being followed in long COVID clinics did actually have POTS. 81% of them were female. So again, the same predominance of male-female is true for patients that have POTS post-COVID. 97% of them were Caucasian. About 95% of them were absent from school or work in the 1 month that they had been evaluated. And 61% of them actually were unable to go to work. So this is, again, it's causing huge morbidity for these patients. And then in terms of prognosis, there's actually not a lot of data on the long-term outcome of POTS patients, but it is considered a chronic condition. So it's something that patients need to live with and has significant impact on the quality of life. I actually saw a patient yesterday who was 34 years old and was coming into the office with a walker, which seems really sad. 50% of these patients only 50% of them may experience a spontaneous improvement, but even that takes about 1 to 3 years. Male patients who don't have any significant comorbidities, like they don't have the Ehlers-Danlos or other conditions associated with POTS, have a better outcome, better chance of improvement. And the patients that actually participate in exercise programs do much better. So in summary, this is a complex multifactorial disorder, requires really an individual approach to management. But again, this is something that in most cases should be diagnosed in PCP's office and managed by PCPs. But understandably, again, these patients, when they come to clinic, they're really frustrated. They feel unseen and unheard because they have just been bouncing from subspecialty to subspecialty without getting much answers. So I think explaining to them some of the underlying pathophysiology, the fact that it's chronic, just giving them the tools to be able to manage their condition better may help decrease their anxiety and help them kind of live with this condition, because most patients will continue living with it. And then actually at Northwest, we do use the Levine protocol for patients with POTS. So I have referred some of my patients to rehab, and if they don't have significant exercise intolerance, in the sense that if they actually can do the minimal amount of activity, they do benefit a lot from it. And again, there's data to show that the patients that have that go to exercise programs do better than the ones that they just try to do them on their own. And then I think our jobs is really not to be managing these patients primarily. Our job is to rule out any other cardiac abnormalities. And if we do, then the rest should be managed by primary care doctors. And which is why I'm working with Alec, Andy, and Gary to kind of come up with strategies to help primary care doctors kind of take ownership of these patients, because also neurology doesn't have the capacity to solve these patients. We just have Dr. Oakley, and his wait times are over a year and a half. And as cardiologists, there are a lot of real cardiac patients that we need to see. So we're trying to come up with dot phrases and protocols to kind of guide the treatment of these patients and give them back to their primary care doctors. And that's all I have for today. So thank you.
Thanks very much, Ninel. We can open it up for questions. Um, I will let, I'm going to experiment with letting people ask their own questions. The first one is from Dr. Thompson. Um, let's see if we can get him. Nope. All right, I'll read his question for him. So he wants to know if if you have any ideas why women have greater incidence of this condition.
So the one thing that I read in studies is that I think it has to do with estrogen and progesterone and hormones, because all of these patients, like also women, have more significant symptoms in premenstrual period. And one other thing, and this is purely anecdotal, I've looked and I couldn't find any research or data on it. I see a lot of patients with gender dysphoria who are under hormone therapy that are presenting more and more with POTS. So again, there's no solid data on it, but I think it has to do with the estrogen and progesterone and the hormones.
Question from Dr. Dean. You covered this, but it seems like our next step with respect to referrals to cardiology is to require the standing test prior to referral. Do you think that's a good idea?
I think that definitely should be done at PCP's office before they get referred to us. But that is something that will be difficult for us to screen and control. We are trying to implement some requirements in the when doctors want to put in referrals to cardiologists, like, patients should definitely have an ECG. If there's concern for arrhythmias, they should have had a Holter or potentially even have an echo before they get in to see cardiology, because that's our role. Our role is to rule out the cardiac pathologies, and if they are ruled out, then they technically don't need to be seen in cardiology.
Let's see if we can get Dr. Poole to have audio. Jennifer, can we see if we can promote? Yeah. Jeannie, I think if you go ahead and unmute, go ahead.
Can you hear me?
Yeah.
Yeah.
Yeah. Right. So that was great. Really appreciate that overview. As you know, in EP, we have, really struggled with trying to figure out how to manage these patients, because we agree that these really should be managed by their primary care physicians. And we used to get flooded with these and just had to put a stop to it. This is going back about a decade now. We were able to make an agreement with neurology and Dr. Oakes that these patients would go to neurology first before that they would come to us, and then they would be referred back to us from neurology if there was a question about needing a pacemaker or, clearly a specific arrhythmia problem. But as you noted, that has gone by the wayside given the wait times and not enough neurologists that are able to deal with autonomic nervous system dysfunction disorders. In the general community, there is a great physician in Bellevue, but unfortunately he switched over concierge practice, and most of the patients can't afford to see him, and there's only a few others. So it's been a major problem. So, we try to block in appropriate referrals to EP on the front end when they come through. And I think that overall that's worked pretty well, that if they haven't been adequately managed by their PCP, or they haven't had a tilt table test done, that we ask them to try to do that first. Sometimes we have to take patients if they're from, our own EP colleagues that have been following patients. But in general, I think it's worked well to whittle these patients down to the ones we absolutely need to be seen. I think one of the really critical things is to explain that to the patient. So if you are referring a patient, to explain that to them upfront, that our role is to rule out a true cardiac problem, true cardiac arrhythmia problem, and that's the extent of what our role in their care is. And then communication with a PCP individually, I think, is also really important. It's a terrible disorder. Ninel, as you mentioned, these people were often highly functioning, and then they got hit with this, and their lives have been ruined. And of course, we've seen so much more since COVID-19 has happened.
And Jeannie, that's exactly what we're trying to do. It's going to be difficult to block all of these patients coming to cardiology. But what we're trying to work on is to say, okay, we saw your patient, the echo was done, the Holter was done, there was no arrhythmia, no cardiac pathology here, and we are handing over their care back to you. And here is we're going to make a dot phrase that we can give to the patients and send it to their PCP. And these are the things you can do to help manage these patients.
Yeah, I think that'll be very helpful, actually, because a lot of the PCPs have no idea what to do with this either. And so that's why they end up being sent to cardiology. So I think giving that educational information back to the PCPs is doing not only the patient a great service, but the physicians trying to manage them also.
Exactly. And that we're currently working on that and trying to implement some of these things into the Epic as well for the internal referrals to make sure they have the initial workup before they even get to us. So it's a one and done visit. Echo normal, Holter normal, no longer need to be followed in cardiology clinic.
I mean, in some cases where, we just try to help the patients and accommodate them, you can send them for the neurology testing and not to a neurology referral. They can get in pretty quickly to at least get their tilt table test done. And they usually do QSART and a bunch of other stuff, but that doesn't take as much time to refer them for that if you really find yourself in a situation where, you just want to try to help the patient and move this along.
Oh, for sure. I mean, I have a bunch of patients that I have started ivabradine or beta blockers or midodrine that then I, end up following because I am the one who
you prescribe the medication.
Exactly. So there are some that, are severe enough and nobody has been able to help them that obviously we will take care of, but there's just a lot of patients that also someone, saw a TikTok video or a friend told them, oh, you have POTS. And, the primary doctors just put in the referral to cardiology because they were asked to. So I think those are the ones that we're trying to kind of limit.
The other frustrating part for me was with COVID and the, clear identification that this can be a viral induced syndrome, that the long haul post-COVID clinic or whatever that clinic is called didn't really do any, prescriptive therapy for the people with clear autonomic instability. And, so the patients would again get referred back to us, even if they'd been followed or seen in the long haul post-COVID-19 clinic.
Exactly. And I mean, other than, yes, and I actually have seen patients that are coming from cardiologists. I have referrals from cardiologists to us. I'm when I see the patient, I'm I am also a cardiologist. Exactly like the one that you already saw.
Yeah.
So there's also that.
Thank you for taking this on, though, because it's really frustrating. And I really like the idea that you've put together a structured way of approaching this, and especially with communication with the PCPs.
Ninel, I want to ask a question that's in the chat here, unless Kavita can unmute and ask it herself. But this question about what we do with folks with this syndrome and then potentially HFpEF or HFrEF, I think is an interesting one. Kavita, can you unmute? Or I will ask. Yeah, go ahead.
Yeah, can you hear me?
I can, yes.
Okay, yeah, so I think we see a lot of patients with either HFpEF or HFrEF with significant orthostasis. and might even be sent to us on midodrine and antihypertensives or Florinef and diuretics, which it's very obviously counterintuitive and hard to educate patients and providers on how to adjust those and change those. So how do you kind of go about that? And then also like HFrEF patients with this orthostatic intolerance, and you want to be able to get them on GDMT. Have you found these sort of non-pharmacologic interventions first to sort of improve their tolerance of GDMT later on? What's sort of, I guess, the best approach? These patients are challenging.
I mean, but I agree, those patients are extremely challenging. Honestly, in my own practice, I haven't seen a lot of, because most of our especially the HFpEF patients are truly, they may have some orthostatic intolerance, but they're not really falling into that POTS category of patients. And I think their pathophysiology may be a little different. They're older, they do have the deconditioning. So I think that trying to fix that deconditioning part may be more effective in those patients than just, compression socks and abdominal binders. I still tell them to do that, but I haven't seen the benefit be as much as I would with, a younger patient that is suffering from these conditions. And obviously the Florinef and the water and salt intake is not something that we can recommend to our HFrEF or HFpEF population. So those are extremely challenging. I have used midodrine in some of those patients, but again, it is very counterintuitive, but sometimes we just don't have any other option because their orthostasis is extremely severe and they can't tolerate being on any medications.
Dr. Linker, you want to ask your question?
Certainly. Excellent talk. I really appreciate your overview. I have an observation and a question. The observation is that for the patients with the hyperadrenergic type, I've found that atenolol among the beta blockers seems to be particularly helpful. I noticed you didn't list atenolol. The question is that as you so well described, there are many different phenotypes with different symptoms and different treatments. Should we maybe have a different name that reflects this broader view rather than not all of them have orthostatic tachycardia?
That is true because POTS, when I think about it, I think it's part of a spectrum because there are some patients that meet the tachycardia component, but their orthostatic intolerance is what bothers them more than the actual tachycardia. So I think it really is a broader spectrum depending on what their underlying pathophysiology is. But for the time being, this is the way it's being broken down. But I do agree that this is more than just, one entity because of their underlying pathophysiology and symptoms.
Dr. Steiner, you want to ask your question?
Sure. Thank you, Ninel. This is a really, really wonderful presentation and practical, which I think is why everyone likes it so much. My question is around referral to cardiac rehab. I think the exercise piece of this is empowering and something for folks to do that they can feel like really take ownership over. I was wondering how you get this approved or covered by insurance, and if not, do you give patients an exercise program that they can follow themselves?
So that is a very good question because if they have private insurance, if it's not Medicare or Medicaid, most private insurances actually cover it, which is great. And then if they can't, then yes, I have printed out like the CHOP modified protocol and given it to them in clinic to take home, or I've actually asked them to download that app, which has the CHOP protocol in it, because I really think that we're not concentrating on the exercise component of this enough because once these patients start exercising, I had one patient who was severely symptomatic. I sent him to cardiac rehab. He completed the 36 sessions. And then at the end of it, I mean, he was not cured, but he was more functional. He had more energy. He could do more on a day-to-day basis. So I think we should try to put in the referral for them, whether it's at Northwest or other rehab programs in the city. And again, in most cases, if they have private insurance, it gets approved.
Tomio, do you want to go ahead and ask your question or comment?
Yeah, mine was pretty much the same question. But I guess to follow up, do other cardiac rehabs, are they familiar with this protocol? In my experience, not a lot of places are willing to take this, and the intensive like neuro PT programs like they have at UW are very restrictive on who they let in.
So yes, they don't like to take a lot of these patients. That's true because they do need a lot of like one-on-one time, especially in the beginning. But I think Evergreen and Swedish both do accept POTS patients. It's just a matter of, getting them in on a timely manner. But I know that at least at our rehab, we do take them. And I have checked with our exercise physiologists in terms of their capacity, and they're more than willing to work with these patients.
And Chris Patton made a comment that the standing test that you were discussing that might be done in primary care offices appears to take about 15 to 20 minutes. In practical terms, how do PCPs or even cardiologists do this in clinic if it takes so long? I'm curious if you have any comments on that.
That is a very good point, because even when I see these patients, even though I know that that would be the ideal thing to do, it is time consuming. It can definitely, I mean, if it's a new patient visit, then you may have that time, you may have that, 40 minutes to dedicate 15 or 20 minutes of it to that test. But yes, it is difficult to squeeze in that test for every patient that's coming in.
I want to ask about the mechanism again. And I appreciate that this is a place where people don't necessarily have all the answers. But you discussed mechanisms, that might be genetic, and then you discussed mechanisms that seem to be exposures, whether it's viral or something else. And then, increasingly we're understanding that a lot of diseases may be the interaction of those two things. And I'm curious if you came across any work or ongoing investigations that try and understand the genetic underpinnings. Small nerve neuropathy or small fiber neuropathy isn't well known anyway, but curious if anyone's working on that you're aware of.
So I didn't come across any research that was like actively working on the genetic aspect of this, but there was one thing that came up in both chronic fatigue syndrome and POTS patients, and that was that these patients have smaller hearts. And again, this is just like one aspect of it, but it was just interesting that both these conditions that have a lot of overlapping symptoms, they had smaller hearts and smaller like LVED, like end diastolic volumes.
Wayne, you want to comment on Aberdeen if you can unmute?
Sure. Ivabridine's gone generic, which is very helpful. You can now get it for about $100 a month using GoodRx, and then they may not need to go to Canada. It's just been helpful for our heart failure patients.
Oh, great. I haven't been able, that's really good news. I have had issues with getting it for POTS. I don't know if that still is.
Well, you can prescribe it off. You can prescribe it off label. It may not be covered by insurance, but $100 a month, these people may be able to afford that.
That's very true. I didn't know that. That's very helpful. Thank you.
Great. I think that is all of our questions. So we'll wrap up our cardiology grand rounds. Ninel, thanks very much for that presentation. Really appreciate it. Thanks everyone for all the engagement and excellent questions. And everyone go out there and be careful on the ice. Have a good day.
Thank you. Have a good day.